Dear students and friends, today in my lecture series on obstetric emergencies, I will speak on the fetal perspective. By this, I mean conditions in which the fetus is at major risk, how to identify it immediately, and how to tackle the situation. I'm sure that my presentation would be useful for clinicians as well. Please note that this presentation is meant only for teaching purposes and the text of which has been updated till November 2020. So, the fetal perspective of obstetric emergencies. By this, I mean what we commonly call as fetal distress. Now, a brief introduction to what obstetric emergencies are. They are acute complications of pregnancy and childbirth which pose a risk to the mother and or the fetus, and however their resolution requires an almost immediate response from the healthcare team, that is within minutes, in order to guarantee favorable outcome. Now, this healthcare team should have a thorough knowledge of their diagnosis and management, but in addition to that, they should have specific technical skills as well, like teamwork skills. There should be a leader within this team. There should be adequate task distribution. Once the work is over, a feedback. Support between team members is essential, and this whole team would work after they have attended simulation based training and drills. Now, obstetric emergencies can be divided into predominantly fetal emergencies and predominantly maternal emergencies. Maternal emergencies I would be dealing with in my subsequent lecture series, but coming to fetal emergencies, first, what we call as fetal distress is acute fetal hypoxia or acidosis, then shoulder dystocia and retention of aftercoming head. The last two conditions in my next lecture, I would be taking them. Now, what is fetal hypoxia? This refers to a condition in which there is decreased oxygen concentration in fetal tissues, and this is insufficient to maintain the normal cell energy production by the way of aerobic metabolism. Before we go into the details, let us understand the pathway of oxygen supply to the fetus. When acute hypoxia occurs, there is rapid reduction in oxygen levels, and this rapid reduction occurs in course of a few minutes. So, in absence of oxygen, the fetal cells do continue to produce energy as required for maintenance of basic homeostatic function only for a few more minutes, and this is due to anaerobic metabolism which sets in. Now, when there is anaerobic metabolism, we know that there is production of lactic acid. The intracellular and extracellular accumulation of hydrogen ions due to this lactic acid results in metabolic acidosis. And this is the reason why we call it as acute fetal hypoxia or acidosis. The whole process is known as hypoxia or acidosis, and in this process, there is decreased oxygen concentration in tissues. Some constituents of the fetal blood are capable of neutralizing these excess hydrogen ions which are produced. So they buffer these hydrogen ions. They are called bases. The bases include bicarbonate, hemoglobin, plasma proteins. Now, subsequently, their depletion occurs, and this is known as base deficit. Base deficit is directly related to the severity of metabolic acidosis. Now it becomes important how to assess the situation. How do we know whether acidosis has set in or not? There is no direct method to quantify oxygen concentration within the fetal tissues. The only objective way is to measure the pH and base deficit in umbilical cord blood at delivery or in the newborn circulation within first few minutes of life. Metabolic acidosis is defined as a pH below 7 and a base deficit in excess of 12 millimole per liter. Sometimes we cannot do a base deficit, And if we do a lactate level, the lactate value in excess of 10 millimole per liter, along with a pH below 7, is metabolic acidosis. However, it is important to obtain blood both from the artery and from the vein as soon as possible after birth, and also to obtain paired cord blood samples. Analysis of this sample, however, should be performed within next 30 minutes. So the cascade of events which occur: increasing concentration of hydrogen ions, which are now no longer buffered; base depletion, which affects energy production and cell homeostasis. All this results in disrupted cell function, which ultimately leads to cell death. When hypoxia is sufficiently intense and prolonged to disrupt neurological, respiratory, and cardiovascular control, then only it would be reflected in reduced Apgar scores at birth. So, Apgar scores are much less specific indicators of fetal hypoxia because they can also be affected by other conditions like prematurity, the use of central nervous system depressors in the mother, birth trauma without hypoxia like in subdural hematoma, infection, meconium aspiration, some congenital anomalies, some pre-existing lesions, or early neonatal interventions such as vigorous endotracheal aspiration. The main causes of acute fetal hypoxia are reversible causes, there could be irreversible causes, some occult causes, and some interventional procedures. The reversible causes are uterine hypercontractibility, sudden maternal hypotension, and maternal supine position, what we call as supine hypotension syndrome. Now, these conditions can be reversible if identified early. However, there are some irreversible conditions like major placental abruption, uterine rupture, umbilical cord prolapse, some maternal cardiorespiratory disorders, severe asthma, hemorrhagic shock, sudden cardiorespiratory arrest, pulmonary thromboembolism, amniotic fluid embolism, seizures, etc. These too have to be managed appropriately in order to save the fetus. Some occult causes like cord compression, so disrupted blood supply because of a true cord knot, a low lying cord, a nuchal cord with stretching. Major fetal hemorrhage is also an occult cause, fetomaternal hemorrhage or a ruptured vasa previa. Some complications of labor like shoulder dystocia and retention of after coming head. So these are the causes which are responsible for fetal hypoxia. Now, besides this, we must understand the consequences. Intense and prolonged changes in neurological function may become apparent in first 48 hours of life. If they are seen in the form of hypotonia, seizures, or coma, this situation is termed as hypoxic ischemic encephalopathy. This is of three grades. In grade 1 is the mild form, in which there is a short period of hypotonia, and this rarely causes permanent handicap and resolves. When the newborn starts developing seizures, then it becomes grade 2. There is a risk of mortality or long-term neurological sequelae, which is only 20 to 30%. But when the neonate goes into coma, it becomes grade 3. There could be perinatal death and anticipated long-term handicap. Another consequence of fetal hypoxia is cerebral palsy. This is the long-term neurological sequelae and is more strongly associated with hypoxia or acidosis. It could be of two types, dyskinetic or spastic quadriplegic types. Although only 10 to 20% cases are caused by this entity. The causal factors are perinatal infection, congenital diseases, metabolic diseases, coagulation disorders, complications associated with birth trauma and prematurity. So these are the main causal factors, but hypoxia is responsible for 10 to 20% cases of cerebral palsy. Now, how to diagnose fetal distress or fetal hypoxia earlier? Acute fetal hypoxia always manifests as a prolonged deceleration. By this, we mean a sudden and sustained decrease in fetal heart rate with an amplitude exceeding 15 beats per minute and lasting for more than 3 minutes. Now, when this duration exceeds 10 minutes, it is said to be fetal bradycardia. So if there is a continuous CTG tracing which is being done, and you see this kind of picture in which there's a drop in fetal heart rate beat 15 beats per minute with a reduced variability within the deceleration, and if it lasts for more than 3 minutes, then it is known as a prolonged deceleration. When this affects the central nervous system, the sympathetic and parasympathetic modulation of fetal heart rate is also affected. It is decreased, and this results in diminished signal oscillations. So what we call as reduced variability. Here you can see that the uterus is hypercontractile, there's bradycardia, and there's loss of variability. This is known as reduced variability within the deceleration. However, the frequency and intensity of uterine contractions determine the magnitude of disturbance and how much they would affect fetal oxygenation. Same thing, you can see here there is tachysystole. Tachysystole is associated with deceleration, with attempts to recover between contractions and reduce variability at the end. Now, during labor, increased abdominal pain is usually referred. But if you've given epidural analgesia, the diagnosis will mainly rely on the reduction or detection of increased contraction frequency by CTG or by fundus palpation. If you find more than 5 contractions in 10 minutes on 2 successive 10-minute periods, or average in last 30 minutes, it is known as a tachysystole. This means increased frequency of uterine contractions. With external monitoring of uterine contractions through a tocodynamometer or fundal palpation, only the frequency of uterine contractions can be assessed. So by palpation, we can only identify tachysystole. Evaluation of intensity, duration, and basal uterine tone requires the use of intrauterine pressure sensor. This technique is not used nowadays. However, intrauterine pressure measurement is the gold standard. If there is a sustained rise in uterine contraction, baseline, or detection of a permanently contracted fundus, this is suggestive of increased basal tone, and this is known as hypertonus. So tachysystole is different from hypertonus. Now let us see what immediate action needs to be done if you have identified a prolonged deceleration. First and foremost thing is call for help. Call 2 midwives, call a senior obstetrician. Assure that there is a continuous and good quality fetal heart rate signal. Then assess the situation, palpate the fundus, or look at the CTG for any hypercontractility. Stop oxytocin if it is being given. If you've given prostaglandins, remove prostaglandins. Evaluate the contractility. After this, do a vaginal examination to detect umbilical cord prolapse or any favorable conditions in which you can easily deliver the fetus. Put the patient in lateral decubitus position. If there are no conditions for immediate delivery. And finally, evaluate the state of consciousness and vital signs. That is, talk to the patient, evaluate breathing, radial pulse, and blood pressure. So these are the immediate actions which need to be taken. The first consideration, however, is for the reliable fetal heart rate signal. A continuous CTG should be started and prolonged deceleration should be confirmed, its duration evaluated, and possible signs of recovery documented. Sometimes it happens that it has occurred only for 3 minutes and then it recovers. So in that situation, nothing else is to be done. You should look for the causes. If there is no cause identified, then wait for a period of 10 minutes. Occurrence of reduced variability within the deceleration is highly suggestive of fetal hypoxia. External fetal heart rate monitoring can be done to assure that the fetus is being monitored. If you do not have a continuous CTG monitoring, assign one person to assure good continuous fetal heart rate signal. At the same time, that person to evaluate the maternal pulse intermittently and document the situation. Many prolonged decelerations, as I had told you earlier, revert spontaneously without any intervention, and so it is difficult to predict in which situation it would occur. All reversible causes of fetal hypoxia should be quickly identified, some immediately corrected, like if there's excessive uterine activity, stop uterotonics or give uterine relaxants. If there's acute hypotension and that too in supine position, then lateral decubitus position would be of help. However, some irreversible causes may pose extreme danger to the fetus, like major placental abruption, a rupture, or umbilical cord prolapse. So, immediate delivery in those situations should be done. When it is not possible to identify a cause, management should be based mainly on the duration of deceleration and evaluation of variability. When there is no apparent tachysystole, oxytocin perfusion should be stopped or prostaglandins removed to reduce contraction frequency and to help recover oxygenation. Subsequently, a vaginal examination is done, same to rule out cord prolapse and to see if the uterus is contracting and if the cervix is fully dilated. In those situations, an instrumental vaginal delivery to expedite the delivery of the fetus can be done. In active second stage, if the woman is continuously pushing, we can ask the woman to stop, could be put in lateral decubitus position that would relieve aortocaval compression and would also reduce uterine contraction frequency. Some situations there could be occurred cord compression. In those situations, a left or right, whichever side is comfortable, decubitus position or a half sitting or upright position sometimes could help. Now, in these situations, we need to establish the maximum time limits because there are time limits for reversal of prolonged deceleration. If it remains there for a prolonged time, it would lead to many consequences like HIE and cerebral palsy. So, in order to avoid permanent injury to the fetus, these timelines should be established. An irreversible cause is identified, like placental abruption, uterine rupture, or vasa previa, prompt immediate deliveries to be done. If you see a sinusoidal pattern, which is suggestive of fetal hemorrhage, then again a rapid delivery. Particular care is recommended when it exceeds 5 minutes and there is no tendency to recover. So if the prolonged deceleration remains for a period of 5 minutes and if there is reduced variability within the deceleration, you should not wait any longer. The healthcare team should start preparing all the requirements needed for a rapid cesarean section, or if the cervix is fully dilated, an instrumental vaginal delivery. In this trace, you can see a sinusoidal fetal heart rate pattern as a result of fetal-maternal hemorrhage. The final decision to intervene depends on local conditions like the distance to the operation theater, the team's proficiency with surgery, how fast they can do it, additional clinical information, whether the fetus was normal or growth restricted, whether there were previous CTG changes, whether there's vaginal bleeding. All these suggest an irreversible cause. Adequately grown, previously well oxygenated fetus at term, the decision should rarely go beyond 7 to 8 minutes. The whole team must be aware of the urgency of the situation and the fetus needs to be delivered within the next 3 to 4 minutes. So the total duration of hypoxic insult at all times must not exceed 12 minutes, otherwise it may cause permanent fetal damage, neurological damage. Now, in these situations, when there is some permanent neurological damage to the baby, litigations are high. So, complications of intrapartum hypoxia constitute major causes of litigation in high and medium resource countries. So we should have an extreme care with clinical records. In these records, it should be labeled and should be clearly written which healthcare professional were called at the time of distress, what time they were called, when did they arrive, who took the decisions, and who performed the procedures. We must also document umbilical artery pH and base deficits or lactate in all situations when there has been some obstetric intervention for suspected fetal hypoxia, especially when Apgar scores are low. This information is important to increase the team's knowledge with management. And this allows clarity of many causes of neonatal encephalopathy, perinatal mortality, and cerebral palsy. A large number of complications, however, are not due to intrapartum hypoxia, and they can be ruled out if you have all this information handy. During cesarean section, it is important to look for causes of acute hypoxia and some which may be revealed at that time. If there is a major placental abruption, the presence of a retroplacental hematoma or a cuvillary uterus is to be documented. In some cases, histological examination of placenta can be done to confirm the diagnosis. Tight nuchal cords, true cord knots, low-lying cords, and ruptured umbilical placental vessels can be detected during a cesarean section or by subsequently inspecting the placenta after delivery. Fetal hemorrhage, if identified, that also requires documentation. So, by careful documentation, many of these litigations can be prevented. Now, the commonest condition which causes acute fetal distress or fetal hypoxia is uterine hypercontractility. This occurs when It may occur when the patient is on oxytocin perfusion. It starts to revert 1 to 3 minutes after the perfusion is stopped because the drug has a half-life of 3 to 6 minutes. If a faster effect is required, or if hypercontractility is spontaneous in nature, which means that oxytocin has not been given, or if prostaglandins cannot be removed, acute tocolysis should be considered. Salbutamol, terbutaline, and atosiban are the commonly used agents, but we must identify which women would require which agent. Like salbutamol and terbutaline should not be used in women who have coronary artery disease, who have history of cardiac arrhythmias, a high blood pressure, hypothyroidism, or low potassium levels. We must keep in mind the side effects like tachycardia, tremor, and nervousness. Atosiban has no formal contraindications, however, has many side effects like headaches, dizziness, vomiting, tachycardia, hypotension, and fever. So these should be identified and it should be used with caution in women who have these side effects. Prolonged decelerations will start to revert 1 to 2 minutes after acute tocolysis has begun. So these are the dosages of the commonly used agents. Salbutamol 125 micrograms at 25 microgram per minute IV infusion. 1 ml vial in 100 ml of crystalloid solution in IV infusion perfusion at the rate of 300 ml per hour for 5 minutes. Tibutalan is given as a subcutaneous injection, 250 micrograms subcutaneous. Atosiban 6.75 milligram IV, 1.9 ml vial is given by IV bolus during 1 minute. Now, another reversible condition in which there could be fetal hypoxia is sudden maternal hypotension. Many women are being given regional analgesia for pain relief at the time of labor. So, during that time, if there is sudden hypotension, it can be quickly reversed by increasing crystalloid perfusion. If it does not reverse by that, we can give ephedrine 3 to 6 milligrams in an IV bolus over 5 minutes. It can be repeated, maximum of 10 milligrams. However, the contraindications are patients with cardiac disease, hypertension, again hypothyroidism, pheochromocytoma, closed angle glaucoma, monoamine oxidase inhibitors being given in the previous 14 days. So we must keep in mind these contraindications. There are some side effects like paleness, fever, dry mucosa, shortness of breath, chest pain, tachycardia, anxiety, nausea, vomiting, headache, insomnia, and mood changes. It can also cause transitory fetal tachycardia. So suddenly the fetal heart rate may increase. Administration of colloids is not recommended in a situation of maternal hypotension as they can have a negative effect on coagulation and they may cause anaphylaxis and acute renal insufficiency. Another condition, but irreversible, is major placental abruption. Here, rapid delivery is to be done to guarantee the safety of both mother and fetus. So, in this situation, mother is also at a risk. Instrumental vaginal delivery, if possible and if conditions are favorable, should be tried. Majority present before the active second stage and therefore require an emergency cesarean section. We must alert the anesthesiologist, neonatologist, and OT staff if there is profuse retroplacental hemorrhage and it may not be identified. In such situations, continuous monitoring of maternal vitals, oxygen saturation, and ECG, a vein catheterized with large bore needle, blood drawn for various studies, coagulation studies, hemoglobin, and cross matching, and a crystalloid infusion is to be initiated. But blood results need to be monitored regularly so that we can identify signs of DIC earlier, and we must always anticipate postpartum hemorrhage in such situations. If fetal death has occurred and the mother is stable, we can induce or accelerate labor. However, in those situations also, we may need a cesarean section if the labor does not progress, there is profuse bleeding, or at any time there is maternal hemodynamic instability. As the diagnosis of major placental abruption is not always firmly established before delivery, the maximum time limits for reversal of prolonged deceleration need to be taken into account. Another condition is uterine rupture. This requires prompt delivery followed by surgical repair in order to guarantee safety for both the mother and the fetus. When the diagnosis is strongly suspected, again, a continuous monitoring of maternal vitals, oxygen saturation, and ECG, infusion through a large bore needle, blood being drawn for hemoglobin coagulation studies. OT should be alerted and should be prepared. After confirmation and delivery of fetus, a surgical correction with a double layer suture may be technically possible, and successful subsequent pregnancies and deliveries through a elective cesarean section have been done. If suturing of a lesion is impossible, or if it is a lengthy procedure and the patient is unstable, then peripartum hysterectomy is the only alternative. Subtotal hysterectomy may be safer than a total hysterectomy with lower rates of urethral complications, maternal mortality, and surgical experience is the only deciding factor whether to do a subtotal or a total. Diagnosis of uterine rupture cannot always be safely established during labor, particularly when the woman is under epidural or spinal analgesia. In those times, the recording of a prolonged deceleration or sudden loss of fetal heart rates is the only diagnostic point. Maximum time limits, again for reversal of prolonged deceleration, need to be taken into account. So to summarize, management of a prolonged deceleration, I would like to summarize with this checklist, which we all should keep handy in case we encounter a prolonged deceleration, which requires immediate management. Continuous CTG, evaluation of maternal pulse. So these are the initial measures. Evaluate duration of deceleration, the variability, call for help, stop oxytocin, and remove prostaglandins. Evaluate the contractility of the uterus, do a vaginal examination, put the patient in lateral decubitus, Evaluate the state of consciousness and vital signs. If you identify hypercontractibility, acute tocolysis is needed. If there is hypotension, start an crystalline infusion or give ephedrine. If there is placental abruption, again, rapid cesarean section is advised or an immediate delivery if the cervix is fully dilated. If there is umbilical cord prolapse, head down position, manual elevation of presenting part, an emergency cesarean section, acute maternal cardiorespiratory arrest should be managed accordingly. Specific mechanical complications like shoulder dystocia, umbilical cord prolapse have to be managed accordingly. The general rules, however, are if we have an adequately grown, previously well oxygenated term fetus, if there is a deceleration and that deceleration has lasted 5 to 6 minutes. So during that period, call an anesthesiologist and neonatologist to prepare the operation theater or consider instrumental vaginal delivery. If deceleration has gone up to 7 to 8 minutes, then go for a rapid cesarean section or instrumental delivery. Documentation is very important in all cases. All your findings have to be adequately documented. If you have any questions, free feel, and you can ask me anytime on my WhatsApp or on this YouTube. Do subscribe to my channel to stay updated. Thank you.